Okay, guys. Welcome back to APS503. This is the third presentation and the final presentation of the subject, and this is on seizures, focusing in on febrile seizures, a hot topic. I am Michael Wood. Let's get on with it. So first of all, what is a seizure? So the nerve cells in the brain communicate via electrical activity, but during a seizure, too much activity disrupts normal communication. So neuronal electrical discharge in its simplest form is the homeostasis of excitatory or glutaminergic and inhibitory or gamma-aminobutyric acid activity. Seizures result from excessive excitation of susceptible groups of cerebral neurons, often in the cerebral cortex or the thalamus, and this causes progressive depolarization of larger groups of neurons. Now, there are different types of seizures, and the International League Against Epilepsy recommends dividing seizures into two major groups. The first is generalized seizures, which are caused by a nearly simultaneous activation of the entire cerebral cortex, or partial seizures, which are caused by electrical discharges beginning in a localized region of the cerebral cortex and may remain localized, and they're more likely to be secondary to localized structural lesions of the brain. So any anatomical differences or abnormalities that may occur during birth, maybe congenital or maybe traumatic and acquired later in life. So there are many possible causes of seizures, including high fevers, brain injury or tumors, as just mentioned, illicit drug use or withdrawal, a viral or bacterial illness, including meningitis, poisoning, and stroke. And on the right-hand side, though, we've got a text box that's thankfully pulled from an article by Sugarman in 2013, and it gives a classification of clinical seizure types. So you can see at the top, we have the partial onset seizures, and down the bottom, we have the generalized onset seizures. And it breaks down partial into simple partial, complex partial, and generalized is broken down a bit further as well. And we're going to go through a few generalized onset seizure types in a few slides. So tonic-clonic seizures, these were formerly known as grand mal seizures. They involve almost rhythmic contraction and relaxation of the muscles, and it's the stereotypical shaking seizure. These are the ones that are portrayed in the media and in Hollywood as the patient quite aggressively shaking and do occur quite often. Absent seizures, which are formerly known as petit mal seizures, usually involve brief stirring spells, and they may go unnoticed by both the patient and curers alike. Atonic or drop attack seizures cause the muscles to suddenly become limp and lose complete tone, as the name suggests, and this results in the patient falling to the ground. And myoclonic seizures cause sudden, brief jerks of muscle groups. So perhaps the right arm will be jerking rhythmically for a short period, and these are more focal than generalized. So let's focus in on one subset of seizures, febrile seizures. Now, febrile seizures are the most common seizure disorder in childhood and a common cause of pediatric hospitalization. They're usually considered relatively benign and self-limiting. However, some cases of sudden unexplained death in childhood have a recent history of febrile seizures, and there are a high number of pediatrics that have suffered from sudden unexpected death in epilepsy or SUDEP. And whilst febrile seizures do not fall under that category, there has been some correlation between the two, but there's nothing been proved as of yet. Now, febrile seizures are defined as a seizure that occurs in association with a febrile illness in the absence of a central nervous system infection or acute electrolyte imbalance in children older than 1 month without prior afebrile seizures. So these are in patients that do not have a diagnosed epilepsy or seizure state. So febrile seizures are then divided into the following three distinct categories: simple febrile seizure, complex febrile seizure, and febrile status epilepticus. A simple febrile seizure is a generalized seizure that occurs once in a 24-hour period and lasts less than 15 minutes. Complex febrile seizures are either focal or localized to specific parts of the body with a duration that are longer than 15 minutes, but less than 30 minutes. And these may reoccur within a 24-hour period. And febrile status epilepticus is a prolonged seizure activity or recurrent seizure activity over a 24-hour period. Now, my explanations of the pathophysiology of seizures, and in particular febrile seizures, is probably not going to be able to beat anything that osmosis can provide. So what we'll do is we're going to watch a couple of minutes of an osmosis video, which is a fantastic explanation into febrile seizures.
Seizures are seizures that happen with a fever. They typically happen in young children between 6 months and 5 years of age. Now, neurons are the main cells of the nervous system. They're composed of a cell body, which has all of the cell's organelles, and nerve fibers, which are projections that extend out from the neuron cell body. Nerve fibers are either dendrites that receive signals from other neurons, or axons that send signals called action potentials along to other neurons. Where two neurons come together is called a synapse, and that's where one end of an axon sends neurotransmitters to the dendrites or directly to the cell body of the next neuron in the series. Some neurotransmitters bind to the receptors and tell the cell to open up the ion channels and relay the electrical message. These are called excitatory neurotransmitters. But there are others which can close the ion channels and prevent an electrical message from going through. And these are called inhibitory neurotransmitters. The main excitatory neurotransmitter in the brain is glutamate. Glutamate binds to NMDA receptors, which tell the cell to open up calcium ion channels. Since calcium has a positive charge, it makes the inside of the cell more positive, and that helps trigger an action potential. On the flip side, the main inhibitory neurotransmitter in the brain is GABA. GABA binds to GABA receptors, which tell the cell to open up chloride ion channels. Since chloride has a negative charge, it makes the inside of a cell more negative, and that inhibits action potential. During a seizure, large groups of neurons become active synchronously, meaning all at the same time. And in a febrile seizure, the trigger for that neuronal activity is a fever. So that makes you wonder, why? Well, we actually don't know for sure, but there are some possible explanations. The first is that a fever raises the core body temperature, and it makes neurons more excitable than usual, meaning that action potentials are more likely to happen. The second is that fever causes hyperventilation, which is when you breathe faster and have a decreased level of carbon dioxide in the blood. That leads to a respiratory alkalosis, or an increase in blood pH, which also seems to make neurons more excitable. The third is that fevers are caused by cytokines like interleukin-1 beta that get released by white blood cells during the body's innate immune response. Cytokines are thought to also enhance the activity of NMDA receptors. Of course, most of the time people have fevers without having seizures, so these factors are just one part of the story. While we don't know for sure what causes febrile seizures, we do know that there are certain risk factors. Genetics seem to play a role, as children whose parents had febrile seizures are more likely to also have them. Age seems to also be a factor, because although febrile seizures happen in children between the age of 6 months to 5 years, the majority happen in children that are 12 to 18 months of age. Generally speaking, febrile seizures happen more often when the fevers develop rapidly, or are higher in magnitude. Febrile seizures seem to be more associated with some infections like human herpes virus 6, which causes roseilla. Febrile seizures can also develop after vaccinations that really stimulate the immune system, like the measles, mumps, rubella, varicella vaccine. But the frequency is quite low, and the benefits of vaccination outweigh its risk. Febrile seizures also always involve a high temperature, or fever, of above 38 degrees Celsius or 100.4 degrees Fahrenheit. They can be classified as either simple or complex. A simple febrile seizure lasts for less than 15 minutes, affects the whole body, and doesn't repeat within 24 hours. A complex febrile seizure is one that lasts for over 15 minutes or affects a specific part of the body which corresponds to a specific part of the brain, or one that repeats within 24 hours. Basically, if a seizure doesn't meet the criteria for being considered simple, then it's considered complex. Having said that, most febrile seizures are simple febrile seizures that last a couple of minutes, and they're tonic-clonic, which means that there's a tonic phase when muscles throughout the body suddenly tense up and go rigid, followed by a clonic phase when muscles rapidly start contracting and relaxing, causing convulsions. After the seizure itself, there's usually a post-ictal state, which is when a child might feel confused and may not remember the episode. They can also have residual arm or leg weakness. Treatment isn't.
So I don't think that I was going to be able to explain the pathophys much better than that video. And it's covered a few things that we've also gone through already so far. So let's go into the clinical features of febrile seizures, and this has been touched on a little bit by the video as well. Now, the prevalence of febrile convulsions ranges from around 2 to 5%, depending on the geographical location that the population has been drawn from. The risk of febrile convulsions increases over 7 times in individuals with a history of febrile convulsions in first and second degree relatives. So these are brothers, sisters, or first cousins, including mother and father as well. 17, almost 18 times in subjects that had a pre-seizure temperature of less than 39 degrees, and a 18 times increase in risk in subjects with pre-seizure fever onset of less than an hour. So these are patients that have had a fever onset of less than 60 minutes with a rapid rise in temperature, and this causes the onset of a febrile seizure. It's also been found that febrile seizures occur more frequently in males. Now, febrile seizures can manifest as tonic-clonic, tonic, or atonic convulsions, and the fevers can occur at any time, which is before, during, or sometimes even after the convulsion has occurred. And whilst febrile seizures are not a form of epilepsy, and the vast majority of children will never develop epilepsy, for a few patients, a febrile seizure can be the first presentation of what is a subsequent epileptic, epilepsy. Now, almost 90% of patients that suffer from a febrile seizure will present with a low-grade fever of less than 39 degrees, but greater than 38. The causes of fever in 48.4% of patients is an upper respiratory tract infection. 18.8% of patients have a lower respiratory tract infection. So it's almost 70% of patients that will present with some sort of respiratory tract infection as cause of the fever and subsequent convulsion. And 14.4% of patients present with acute gastroenteritis. Now, it's also important to remember as well that whilst febrile seizures are usually self-limiting, 1 in 3 children who have a febrile seizure will have another one during the subsequent illness. And this accounts for the 30% of patients that then have complex febrile convulsions. So the physical examination of these patients, the first step in the examination of the seizing patient is to obtain a complete set of vital signs, including a point of care BSL and assessing for any injuries to try and ascertain potential causes of the seizure. Any significant rashes that may be associated with invasive meningococcal disease should be noted and addressed, and it is essential to identify the presence of any red flag signs. So any non-blenching rash should be aggressively treated with benzopenicillin. Basically, it's a treat the cause and don't just try and treat the symptoms at the end. Now, in terms of physical examination, a lot of people may not have seen seizures, particularly new paramedics or new nurses and doctors. So I thought we might throw a video in that's about 2 minutes long of a small child, I think from the video, about 2 years old, that's experiencing a febrile seizure. Now, just a moment as they come down the stairs and turn the lights on, and they pop the child onto the couch. A nice safe space, nice and comfortable, making sure that the patient's not in any danger. So as you can see, the rhythmic contractions of the muscles.
Come on, baby. Come out of it, baby.
And make note of the patient's respiratory effort during this time.
Please, Max. Come on, Max.
So what I might do now is I'm going to skip through just around to about the time that the patient starts to come out of the seizure. And you can see now that the patient's breathing is quite noisy, but the rhythmic contractions seem to have stopped. The patient looks, quite frankly, exhausted. And a lot of airway secretions as well. Okie dokie. So that's just a quick presentation, a quick video rather, on how some febrile seizures can present and something that can be looked out for. And those parents did quite well. They took them to a nice, comfortable place that was safe, and the patient wasn't going to get harmed in any way. But if you may have heard that they said that the seizure had been going on for approximately 5 minutes, perhaps best for emergency services to have been called for administration rather of a benzodiazepine or an anti-epileptic medication. Now, some relevant investigation into febrile seizure and patients that have experienced a febrile seizure. And the most important acute investigations of a child with febrile seizures relate to identification of the underlying illness and how the illness might have precipitated the seizure or influenced the seizure type. Basic investigations that are not available in the pre-hospital arena, however, include a full blood count, electrolyte levels, C-reactive protein, which is an inflammatory marker, blood cultures, and urine dipsticking cultures. And these are all commonly ordered on arrival to the ED. And this is searching for infective processes or infective background that may give light to a cause of the fever and subsequent convulsion. Now, how do we manage patients that have experienced febrile convulsions? Now, general medical care should be continuously provided to patients with any type of seizure presentation, and management and assessment of the patient's airway is extremely important. As you could see during the video, the patient's breathing was quite raspy and noisy. There's a lot of airway secretions, and respiratory effort was quite diminished at some stages. Now, in most cases of febrile seizures, the seizure will have terminated prior to the arrival of emergency services, though this may not always be the case. And so, as with any and all patients, the management of a patient experiencing a seizure should begin with a thorough and sound primary survey, assessing for any compromise of the patient's airway, breathing, and circulation, and any insult identified during this time should be treated immediately. So following your primary assessment, the patient should be managed in this way. So if the patient is still seizing, you want to protect the child from injury. You want to immediately administer midazolam and call for urgent backup. If the patient is not seizing, you want to assess for airway patency, placing them lateral without an airway adjunct, place them supine if you have an airway adjunct in situ. You want to make sure that you've suctioned the patient's airway quite well to remove any excess secretions. You want to administer high flow oxygen during the initial post-ictal stage, targeting oxygen saturations of greater than 94%. You want to establish a patent IV access if possible. It's obviously quite difficult in pediatric patients. You want to identify and treat any potential underlying causes. And you want to manage fever and rapid changes in core body temperature. Consistent attention to ABCs and repeat primary surveys with frequent repeat assessment of baseline observations will allow you to identify any trends and changes in your patient as well. So when managing the seizing pediatric patient, it's paramount to remember that you will not only have to manage the patient, but also the parents. Ensuring ongoing commentary, communication, and updates to the patient's parents is just as critical to ensuring control over the situation as ongoing patient management. You want to ensure that the patients are involved in any decision-making process and consistently informed of what's happening with their child to make sure that they become a help and not a hindrance. Now, on the right-hand side here, I've just put up New South Wales Ambulance's flow chart and protocol in regards to patient management. And whilst it does not specifically differentiate between different types of seizures here, that's quite good, because what you want to do is if you see the seizure, you want to seize the seizure. Once you stop the seizure, then you can start treating associated conditions, so maybe hypo or hyperglycemia or hyperthermia, as is noted here. And you're looking for the cause after you've treated what's going wrong. So how are you actually going to treat these patients pharmacologically? Now, ambulance services, including London Ambulance currently, have historically used rectal diazepam as the primary pharmacological intervention in pediatric seizures. However, most evidence has shown that best practice is the administration of intramuscular midazolam, which is luckily what New South Wales Ambulance currently uses. The aim of pharmacological interventions in the seizing patient should be to directly seize the seizure before correcting underlying causes, as is just said. So, for example, if the patient was found to be hypoglycemic and not febrile, you'd want to administer glucose, bring them into a euglycemic state. Another hot topic, if you excuse the pun, is to be wary of deciding to administer antipyretics. There's been no proven evidence that reducing fever confers to patient benefit, particularly in the infected patients. Most patients benefit from a low-grade fever. It's a natural and innate immune response to fight infection. So what will you administer these patients? So I'm going to use New South Wales Ambulance protocols here. So quite simply, oxygen and midazolam. So oxygen, you're going to administer it titrated to a SATs of 94%. Now, this is to ensure aerobic metabolism and to mitigate any potential acidosis. And as was mentioned whilst watching the video of the patient earlier, patients can often be apneic or have very poor respiratory efforts during seizure activity, and so additional oxygen is quite beneficial. Midazolam is going to be administered at 0.15 milligrams per kilogram. If it's intramuscular, it's going to be undiluted, and if it's intravenous, it's going to be diluted. Now, midazolam enhances the affinity of the inhibitory neurotransmitter GABA, or gamma-aminobutyric acid, to the GABA receptors, which causes an influx of chloride into the cells and makes it basically decreases the ability of neurons to depolarize by changing the polarity of the cell. Once you arrive at hospital, however, if midazolam has not worked in maintaining a non-seizing patient, they'll often be put on infusions of phenytoin, valproic acid, or phenobarbital. Now, phenytoin is a 20 milligram IV load, which is then topped up with 5 to 8 milligrams per kilogram per day. And it's a sodium channel modulator. So once again, we're acting on the polarity of cells, trying to decrease the ability of cells to depolarize. Valproic acid, 20 to 40 milligrams per kilogram IV load, then a 10 to 15 milligram per kilogram twice per day dose. And similar to phenytoin, it's a sodium channel inhibitor, but it also has GABA potentiation. So it's going to increase the affinity of GABA to the GABA cells as well, which increases chloride influx. And it's also going to inhibit the excitatory NMDMA receptors, which stops glutamate and subsequently calcium entering the cell. So everything here is obviously geared at changing cell polarity and decreasing the ability of cells to depolarize, much similar to phenobarbital, as it enhances GABA inhibition by modulating chloride currents. And the dose here, 20 milligrams per kilogram IV load, then 1 to 4 milligrams per kilogram per day, and that's twice daily. Transport decision-making processes for these patients. So certain life-threatening conditions require immediate, meaningful treatment of reversible causes whilst on scene, with all other treatment en route and rapid transport to hospital for further assessment and treatment. We've also got to consider geographical considerations. So how far away from definitive care are you? Do you have time for extra assistance to get to you, or can you meet them en route to the hospital? The classic dichotomy of load and go or stay and play. So you've also got to consider the ability and capability of receiving hospitals. Some smaller rural hospitals may be worth bypassing if patient's presentation allows, particularly for pediatric specialties, pediatric trauma, or any specific pediatric issues that may end up delaying definitive care. And as always, you want to make sure you pre-warn the receiving hospital with a back call. You want to let them know what's about to roll through the doors, particularly if you have a critically unwell patient. With pediatrics, many pre-hospital clinicians tend to err on the side of caution and rapidly transport when presented with the challenge of managing the critically unwell pediatric. This may not always be best practice, however, if it comes at the detriment of a full and thorough patient assessment, which then allows for the timely management of potentially life-threatening issues such as airway compromise and apnea, may not be what's best for the patient. It's been found that children are often transported to hospitals with specialty pediatric resources in almost 75% of pediatric cases, and this may be highly beneficial for patient outcomes. Whilst this says that transporting patients to pediatric specialty pediatric locations is beneficial, it doesn't necessarily say that they should be transported there at the detriment of performing a thorough assessment and treating the required ailments. Now, leadership roles as a critical care or an intensive care paramedic. As a senior clinical practitioner in the pre-hospital arena, your role is not purely clinically based. Clinical leaders need to have a sound perception in both scene and crew resource management. And whilst diagnostically unwell patients require urgent, accurate, and efficient management interventions, and teamwork is critical for both patient and provider safety in high-stakes environments. Critically unwell pediatric patients are confronting situations for even the most experienced clinicians, and it will require additional crew resource management skills to ensure that clinicians stay focused on the tasks at hand. Ensuring that the parents of the child are well managed and involved in discussions regarding patient management and disposition may be difficult at first, but will allow for the job to run much more smoothly. Accurate drug dosing in the pediatric population can also be difficult, and this is going to really draw on your leadership ability and your ability to crew resource manage. Excess dosing of midazolam often occurs, and it has been associated with respiratory insufficiency and the need for ICU admission. Close monitoring of drug doses and administration is key for full oversight of these same. So let's have a look at 4 key takeaways for the management of patients suffering from febrile convulsions. Febrile seizures are very common, and they occur up until the age of 5. They present as simple febrile seizures in about 70% of cases, and they are usually self-limiting. If any seizure activity is witnessed by a clinician, however, early pharmacological intervention is paramount for best patient outcomes. And finally, and definitely not least, parental concern for the patient and involvement in decision-making processes is key to ensure the best outcomes are attained. As mentioned before, you want to make sure that that parent is a help and certainly not a hindrance in any way, shape, or form. They've given you the child in a severe time of need, and you want to make sure that you're telling them exactly what's going on and what you're doing for that patient. So there we go. That's my presentation on febrile convulsions. I've left the references up on screen for you if you want to go away and have a read of any of them yourself. Thanks very much, and thanks for listening to my presentations throughout the whole subject. Thanks a lot.